Good afternoon. My name is Camilo Castillo. I'm the medical director for the spinal cord injury program here at Fraser Rehab, University of Louisville, in Louisville, Kentucky. Today we're going to do the first interview series to specialists. The first surgeon is going to be Dr. John Shaw, who is a physiatrist and orthopedic surgeon here at the university. He has served the rehab community since 1982. Dr. Shaw has spent 12 years pioneering orthopedics and rehabilitation in Korea, and he started the first dedicated rehabilitation center there in Korea. He came back to Louisville, where he completed a residency in physical medicine rehabilitation and began his career with our hospital. When he had the opportunity, he further expanded rehab our region, and he became the director for our Southern Indiana Rehab Hospital. He served director for 23 years. Dr. Shaw is a very special interest in hand diplegia, particularly resolving problems of spasticity and enhanced function in spinal cord, brain injury, and strokes. He has returned to international work, including Korea several times, to train surgeons in tetraplegic hand and lecture to career rehab programs as well. Um, Interesting enough, his first residence studying orthopedic and rehab residency program in Korea. And in 2014, a new rehab hospital was built and named for Dr. Shaw next to the Presbyterian Medical Center where he worked during his times overseas. This interview is going to be obviously in English and is going to be translated in Spanish and Portuguese. Thank you very much, Dr. Shaw, for willing to do this interview. So you have so much experience with hand surgery. You are the few orthopedics and rehab doctors in the United States. There are not many like you who does. What led you to be interested on both rehab and ortho at the same time?
Well, when after I did my orthopedic training, we went to South Korea, where I started orthopedic residency, and we were dealing with so many disabled people, particularly children with polio, leprosy, tuberculosis, osteomyelitis, all kinds of things that young and old. But this led to the necessity of really comprehensive rehabilitation. And my wife is an occupational therapist. So we started a multidisciplinary rehabilitation work, and we took in a carpenter to start doing the orthotics, prosthetics. We took over an old pizza oven to use to create prosthetic devices. We'd cannibalize all kind of prostheses to make things for joints and feet and so forth. And we did a nationwide training course in rehabilitation nursing. We did a lot in speech therapy and psychology. So we basically put together a rehab team, and we were able to, which in Korea was hard because it's hard to do that as a team, but it became the Institute of Rehabilitation, the IRM, Institute of Rehabilitation Medicine at that hospital. So it was the first organized. We had our own building attached to the hospital, organized comprehensive rehabilitation with everything that we had a speech therapist come in from Hawaii, trained in Hawaii. So we had every component we needed to develop this kind of strategic rehab team. And so that was how I really got introduced to rehabilitation as a necessity. I really didn't know that much about rehabilitation medicine as a specialty, other than I thought we were doing it. So as I mentioned last night, in 1980, we had just opened the Institute of Rehabilitation Medicine, and the anesthesiology resident from Seoul came into my office and said, "I want to be your first rehabilitation resident." So I said, "Okay, you mean whatever that is, rehabilitation was not a much of a specialty at that time." And I said, "That'd be good. Let's do it." So they start their year in the usually March of the year. So I was coming back here, and we happened to come to Louisville only because the school burned down when we were going to Atlanta for furlough. So we came to Louisville, and I looked up, there was a rehab facility here, and Barry Smith was the director at that time. And so before I got here, I said, well, maybe I can get in the training program in rehab, find out what this is, And so I started doing the rehab training here. And because I already had the orthopedic background, I only have to add 2 years. So, so I brought my resident to Louisville, and she spent a year with me here during my time here. So we were residents together. My first resident was my resident. We were residents together. And we went back to Korea. We returned to Korea after we left Louisville. And then she finished out her training program. She was probably one of the first trained rehab doctors in the country at that time. And we started a residency in rehabilitation medicine. And last night you saw both our very first and second rehabilitation residents, now very huge people in rehabilitation in Korea and internationally. And my first orthopedic resident was there, Dr. Pak, and he also went to Seoul, became an outstanding leader and the head of a big rehab program in Yonsei University, and now the head of another hospital in another city where I had gone a few years ago and I'm doing teaching for rehab surgery in the tetraplegic hand. So, I mean, all of this evolved as an outgrowth of that. And so that's when I came back to the States. I really started integrating rehabilitation, surgery, and I, at that time is when I ended up staying here because David walked, 2 people here wanted to form a group, and so we formed that first group, Rehab Associates.
So let me ask you this. So after all this amazing training that you have and all these good things you did in Korea and then you replicated here, with all your experience, let's move forward to our time when we have medicine that we were talking about just before we started this interview, how fast it is. What would be the first, the things that you look for in 2021 for a patient who have acute spinal cord injury, tetraplegia, and we ask you, which I did many times for you, and you were very kind and humble to come to the unit and see the patients where they were here in such a, dramatic situation for the patient. What do you see? What do you do with these patients first for our people in Latin America and United States to understand? What do you do?
Well, I think that is Dr. Steele, that's a prime important question, because the most important thing is first of all, introducing yourself to a person. You want to start developing a relationship. You want to develop that confidence that you do so well, because this is a person that's probably going to have a lifetime disability and multi-organ systems. And there's nothing more important at that time than to acknowledge where they are, often hear their story. They're often wanting to tell you their story. They may be a fresh injury, maybe in a collar, had surgery on their neck, and they've got possibly a spouse or a parent sitting next to you. So it's really important to engage that unit, and equally important to engage the spouse or whoever is there in that room. And so the most important things I start doing is becoming a traveler with them, as you do, because this is a lifetime travel. And in terms of the upper extremity, it's equally as important in lower. The upper extremity, your most important thing is observation. And it's always great if the therapist can be in there with you from the beginning. So the occupational therapist particularly, and the nursing, if they could be there, because there are certain things you are observing and are wanting to really emphasize, but you want to do it in a delicate way. You're doing it not in a way, at no time do I bring up surgery at that point. For one thing, they don't believe they will need surgery. They still believe they're going to have a recovery, and they may well make a recovery that we have no prediction of. even though we may know, okay, so it's very important to me when I do this, I know myself what the progression will be, but what I want to do is have that bond of confidence from them. And even as I'm examining them, I am really developing that confidence. Now, here's what I really am looking for. I'm really looking at what kind of range of motion do they have. It's so important because if they're in that hospital bed and doing, it's so easy to neglect range of motion. And if we're talking about the arm, we're talking about the shoulder, the elbow, the wrist, the hand. And the more hands-on you get, so you get that tactile feedback, the better. So I am, as I'm talking to them, I'm kind of moving their arm, I'm handling them, I'm letting them feel my contact. And also, they oftentimes have a lot of sensory loss. So that is important for therapists and nurses to give them that sensory feedback, to give them that sensation of touch is so important. So I'm looking for range of motion. I'm looking for any evidence of contracture. And I'm looking for what kind of sensation they have. The biggest enemies to that upper extremity, that progressions are, number one, the lack of range of motion, maintaining range of motion, to edema. Edema is a real killer because oftentimes edema occurs in the hands because they hold their hands in their lap, they get dependency, and oftentimes I see them come in the clinic, hands in their lap, great big swollen, and they sometimes don't realize how edematous their hand is. I often tell them, this is like pouring concrete in your hand because you have so many muscles, so many tissue in those hands that you've got to keep the edema out. So it's important to reduce the edema, maintain the range of motion, give them sensory feedback, and help them feel confident. And so then if the therapist there, really saying this is what we have to do to keep that good range in the shoulder, in the elbow, you want to maintain good extension of the elbow because the tendency is they'll lay in the bed with their arms flexed up like this, and oftentimes the wrist drop down like this. And so it's important that they get that good passive range, passive blocking of the arm as necessary, good elbow extension with splinting at night, and maintaining wrist flexion extension. The tendency is the wrist drops. When the wrist drops, it gets tight. So the flexors are always overpowering the extensors. Finger flexors, wrist flexors, elbow flexors, shoulder adductors. So I think that is where you start, and you're gently walking through them the time you have there, maybe 6 weeks, month, 6 weeks, 8 weeks before they go to outpatient. So that by the time they come into outpatient, I know the patient. We have a relationship, we have confidence, and we're building on the things we've started. And the therapists are deeply involved. You just have to be like a hawk to keep that range going in the shoulder and the elbow, the wrist, and the hands, possibly using isotonic gloves for the hands to reduce the edema, splitting to prevent the wrists from falling down, elbows to keep the elbows out, maintain good range. So that's your main goal in that.
John, let me interrupt you. I'm sorry to interrupt you, but some research have shown that instrumental learning, the spinal cord, can be affected if you do too aggressive range of motion. What do you take on that?
Well, I don't think you can do too aggressive range of motion. I think you're doing functional range of motion. You don't have to exaggerate the range of motion, but in terms of what you're trying to achieve, knowing this patient may be a candidate for surgery, I know the kind of range of motion they need to have that. So it's not an exaggerated range of motion, but the elbow is critical to get that terminal extension. The wrist is important to get that dorsiflexion. Finger extension is important, that passive range. So I wouldn't use the term aggressive range of motion, but very functional. And again, that's human contact while you're doing it.
So this is great. So in order for us, or for people who are watching this interview, there are some fundamental differences between what is tendon transfer. People get confused about these definitions: nerve transfers, tendon lengthening, tenotomy. Can you tell us small definitions very quickly so people can understand, and how do we focus each one of them?
Well, basically, there are really two major things that we are focusing on in the upper extremity reconstruction in time. One is tendon transfers, one is nerve transfers. Tenotomy is where you just cut the tendon loose. Now we do tenotomy more in the spastic arm, and we may do that in a spastic extremity of the spinal cord. And when we do that not just cutting the tendon loose, but you're doing a release within the context of the muscle, so you don't lose continuity of the tendon. So the main things, that is something that may be part of it. But in tendon transfers, first we want to maintain that good passive range of motion, supple hand. And so we're transferring a muscle. We're usually transferring a muscle, oftentimes that is a antagonist. So if we're trying to, or it's really a synergistic movement. If I'm trying to get finger flexion, and I get finger flexion by a wrist extension, it makes sense to take a wrist extensor to provide finger flexion. So a tendon, the most common tendon transfer to get finger flexion is a wrist extensor, because you activate it the same way. So we are same way in the elbow. We are using an elbow to get elbow extension is the main thing. We really have two options. We can use a biceps tendon as a transfer if they have brachialis or they have brachyradialis. And we can use a posterior deltoid. Posterior deltoid is a common one that we transfer. So it's very important that we maintain good range of motion and good strengthening of the various parts of the deltoid. So the two main things then are tendon transfers. The other one is nerve transfer. Nerve transfers have become really a big topic. The leading people in that whole arena right now has been Australia in the presentation and the work, but it is just really, really becoming and so important, because the value of nerve transfers, when we talk about how you evaluate a tendon for a person for tendon transfers, nerve transfers give you a window of opportunity to do something that you don't have available with a tendon. And the most common one that we use are to open the hand. Before nerve transfers, we didn't have enough tendons to open the hand, but with nerve transfers, we have a fairly good success if they're properly selected to give them hand opening. And to use a hand isn't too helpful if you can't get it open to be able to do something with. So traditionally, we've had to do what we call tenodesis. In other words, for opening the hand, we've traditionally had to do where we would plug the extensor tendons into the bone on the back of the hand to produce a tenodesis grip, which is okay, but when you add a flexure to it, it'll overpower it. And it's still sometimes hard to get the hand open. So the place for nerve transfers is very valuable in the selected kind of patient. So the two main nerve transfers are, one, to open the hand, and number two, to close the hand. So, and that has been something that you selectively have to decide. And
that's my next question then. What are the inclusion criteria to consider surgical reconstruction in your patients after spinal cord injury? And what type of approaches, now you mentioned a little bit about that, but what type of approaches do you propose, and what are the differences between them, and how do you approach them?
Well, I think the thing is, as we progress along, first I would like to mention that what's important to evaluate the tetraplegic upper extremity is what we call the international classification. The international classification was something that was developed by a group of hand surgeons in southern France in 1984. And I was fortunate to be part of that group. So the therapists become familiar with this. And what I want to do is, I'm not going to go through the whole, I will go through it, but I want you to remember a couple important things. This is apart from the Asia scale, which is important for evaluating people for surgery. So the very number one level of the international classification is the brachioradialis. That's one, and that's an elbow flexor. So there is no classification for the arm in the shoulder. The first one is an elbow flexor. Number 2 and 3 are both wrist extensors. Extensor carpi radialis longus, extensor carpi radialis brevis. Now at a grade, each grade has to be at least a 4+ or better strength to use them, to categorize them, say, as a 2 or a 3. So I'm only going to go through the first few. Number 1, brachioradialis. 2, extensor carpi radialis longus, extensor carpi radialis brevis. Number 4 is the pronator teres. So number 4 is pronator teres, and number 5 is flexor carpi radialis. That is the lowest level for a C6 level spinal cord injury. For tendon transfers, we have to have at least a level 3 to consider tendon transfers. Anything above level 3, you cannot do tendon transfers because you only have one tendon. The reason is because of the 2 radial wrist extensors, the extensor carpi radialis brevis comes off at a lower level in the spinal cord than the longus. And the last thing you want to ever do is lose your wrist extension. If you lose your wrist extension, you lose the hand. So there's always a risk if you use an extensor tendon for the wrist and lose the wrist hand. So what I always tell the therapist, the most important muscle to know if it's a number 4 is the international classification number 4. That's pronation. Because the pronator comes off just below the level of the extensor carpi radialis brevis. So if the therapist, if I say to them, does this person have a strong pronator and you can't break it? Bingo, that is the criteria for knowing I can do tendon transfers on this patient. If they lack a pronator, they're in a class that I am not sure of. Because if you take away the brevis or the longus and you got a weak brevis, you've got a lost case. So that's the point where nerve transfers suddenly descend. The beauty of this is a patient that is say a C5 quad, if they're international classification 3, and I can't get a strong pronator, they are the patient I am looking at right away for a nerve transfer. Because with a nerve transfer, if they're the candidate, we can get the hand open and then thumbed open. So what do we do in that early stage, even ideally even before a year? You have a golden time to transfer the nerve of the supinator nerve to the posterior interosseous nerve. It takes about a year for this to work. But by being really careful with your electrical studies, doing the compound action potential, and studying.
I'm sorry to interrupt you. I'm sorry to interrupt you, John, but can you explain why do you say it takes a year? Because tendon transfer, you can do it sooner. But
well, if you're trying to tendon transfer, it's immediate. Right. Nerve transfer, you're putting a donor nerve, for example, the supinator nerve, into a recipient nerve, say the posterior interosseous nerve, and that nerve has to go down the length of that nerve about a millimeter a day. So usually you'll see it 8 to 10 months, the flexor side even longer. So it actually can get better for up to 2 years. That is the problem that anxious surgeons have. You're not patient. But and you know, let's do surgery, but the beauty is if you could get that hand open and get it strong, because if you do it too early, you'll overpower it with the flexor phase. That flexor phase is very powerful. So the nerve transfer is great to consider for anybody in that international classification of 3 2 or 3. If they have wrist extension and they're a grade 2 or 3, the spin procedure, supinator nerve to the interosseous nerve, has been about people that don't do a really good evaluation. Some of them aren't getting very good results, but people that have the really good studies and know and say, okay, this is a candidate, I'd say about 50% of those can get good results.
Thank you very much to Dr. Shaw for this wonderful portion of the interview. Appreciate the time you have taken to explain us all this part of the management of the diplegia hand.